I have the pleasure of talking about our work at Women's Health and Women's Hands Community Health Center. I'm the historian today, and there are many people who are part of this journey, and there are many more qualified people who could stand up and give this historical perspective. So I hope I do it justice, but I think the work that has already been done around FGM should be noted and acknowledged, because we don't want to keep repeating the same mistakes that we've made in the past. And I know all of you are here because you're committed to working on this issue, committed to learning about the issue, and moving forward with actually having a very solid platform that Canada can be very proud of in terms of supporting women and ending violence against women in all of its forms. What I'm going to be looking at today is about our organizational leadership and how an organization took part in dealing with an issue that really fell in its lap. It's not something we went out and looked for. It's something that the community came to us and asked us to deal with. And I'm also going to be looking at the strategies that were employed by our organization and how an organization needs to work effectively with communities, particularly marginalized communities in Canada, and particularly around an issue that was so extremely taboo that we didn't have any resources or tools to deal with it at that time. So, as you've already heard, FGM became a matter of international concern around the 1970s and throughout the 80s. And Western feminists are the ones who brought this to international public attention. They described the practice as barbaric and labeled female circumcision as a human and reproductive rights abuse against women and children. And I'm using the language that was used at that time, that was often written about. And what that ended up doing is pitting Western feminists against African feminists around the issue of FGM. And it's important to note that because sometimes we still are carrying around that language and that sort of ideology that the practice is barbaric and these people are crude and primitive, and that's how we perceive African women to be. We often describe African women in very passive terms, that they're victims, that they don't have agency, that they lack power, and they need saving. So I know that I'm using very harsh language, but it's the language that is sometimes not really spoken about. It's under the surface of how people talk about this issue. And as African women, we're not often perceived of as advocates. We're not often perceived of as strong women. People think we didn't become advocates until we were freed when we came to Canada, that we aren't in our countries of origin fighting for our rights as women. The other issue that was a really big thing that needed to be discussed is that FGM is often seen as an isolated situation. It's just this thing that those people do. And there's no link made between social and economic oppression of women globally, that women experience violence all over the world. And this is one form of violence that women experience. At Women's Health and Women's Hands, and for many of us who are doing this work, what we wanted the Western feminists to start looking at is a violence against women framework, as opposed to just pulling us out and isolating us and actually stigmatizing us further. We wanted to be incorporated into the whole matrix of other types of violence that women were experiencing, dependent on which country they lived in, what their culture was, what their ethnicity was. There's no culture that's more violent against women than another. We just experience violence differently dependent on where we're located at a particular time in our lives. We also wanted people to understand that violence against women had no political or cultural or social barriers, and that situating FGM within a violence against women framework eliminated this attitude of Western superiority. So your violence is worse than the violence that I experience, right? This is worse than domestic violence. This is worse than the type of sexism you might experience in Canada, for example. So situating FGM within a framework that discussed violence, it moved that conversation away from those women and their practice to the global fight to end violence against women in whatever form it takes. So that sounds different, right? Those women, their practice versus we're all in this fight together as women because women experience violence all over the world. We're also moving FGM within a violence framework because it's the first step to having the practice criminalized in Canada. So to move it to be alongside of things and types of violence that are already legislated as criminal or crimes against women was the first step to ensure that it also became criminalized in Canada. So just to give you a sense of what was happening, my family immigrated to Canada in the 1970s, and we left Sierra Leone for Grand Falls, Newfoundland. We were so for those of you who are not from Canada, Newfoundland is the most eastern province in the country, and I think it's not the smallest, but it's one of the smallest. We were the first black family to arrive in this community in Newfoundland. That's another presentation. But we were coming from Sierra Leone, and we were coming by choice. Most African migrants are coming to Canada in the last 20 years, and it's forced migration. Forced migration because of war, because of globalization, because of violence, because of untenable situations in their country of origin. Forced migration is very different than the migration that many of us experienced in the 60s and 70s as black people coming to Canada. Forced migration leads to an enormous amount of instability that has absolutely nothing to do with FGM. And so you're coming into a Canadian immigration system that is not as supportive as the earlier one that many of us came in. But in terms of the migration patterns of African people, looking on this map, just the brownish, reddish areas, those are the areas that practice FGM, and then the darker the color is the higher prevalence rate of FGM. I'm from Sierra Leone, and our prevalence rates of FGM, 95% to 100% of all women in Sierra Leone have experienced FGM. These are also the countries most represented in Canada. So the African migration during the 80s and the 90s also are the countries with the highest prevalence rates of FGM practice. So that's something of interest, and like I said, that's a whole other issue around why those countries and why FGM is so high in those countries and what's happening for women in those countries. But those are the people who we are receiving as immigrants and refugees in Canada. Canada cannot survive without immigration. So we can't ignore the issues that are coming with the populations that we need for Canada to survive. So what was the environment that people were coming to at that time? Canadians are tolerant people, some would say too much so, but on this matter there is no middle ground. We will not permit the immigration of female mutilation any more than we would permit an Arab's hand to be severed if such a person were caught shoplifting. We are more civilized than that. And isn't that one of Canada's redeeming qualities that attract new citizens? This is the Niagara Falls Review, a newspaper in 1992. This is not an unusual quote. I just decided to pull this one out. I thought it had some really neat buzzwords in there. But this is the public attitude at the time of most of African migration happening in Canada. In terms of service provision, what was happening around this time? Having my first child in Canada was a very scary thing. I did not speak the language and did not have my family here. When I went for my first prenatal examination, the doctor gasped and said, "Oh my God." He had never examined someone who had FGM. I felt humiliated and exposed. When I went to the hospital to deliver my baby, the doctor called on his colleagues to come and look at me without my permission. This is not a humane way to treat someone. This is from a study we did where we interviewed women from FGM practicing countries and their experience with healthcare in Canada. So we were trying to build a case for improvement in the healthcare system. by getting the stories directly from the mouths of the women who were having these experiences. So political environment wasn't great at this time. Service provision, healthcare, really not accepting of the communities that were coming to Canada. So as an organization, before we started doing this work, the most important consideration that we had to make, and for those of you who are service providers, these are considerations that I hope you need to also think about. What type of strategy would be most effective when working with a community which has already been alienated, shamed, stigmatized by insensitive service providers, by racism, and a hostile public influenced by biased media? So, as a service provider, I'm now going to work with a community which has been extremely isolated and does not want any more negative attention. And I want them to talk very openly about FGM. I want the women to be able to walk into the center and ask for services when they know it's a hostile situation that they're walking into. So what are the things that I need to do to mitigate this relationship with a particular community? And I'm sure many of you are also grappling with that question. Women's Health in Women's Hands was in a really unique position to do this work. We are, and just in case you haven't noticed, it's our 20th anniversary this year. And we are the only community health center in Canada for women, unfortunately. We don't want to be the only community health center for women. And we specifically serve 4 populations of women: African, Caribbean, Latin American, and South Asian. So Canada already has not committed and invested in gender-based health care. But we've been lucky enough to have this one small community health center in downtown Toronto that at least works with immigrant and refugee populations. And our mandate is to provide primary health care from a feminist, pro-choice, anti-racist, anti-oppression, participatory framework. So this is our written mandate. So it put us in a really unique position because of who we served. We had a mandate that was committed to anti-oppression and feminist values and pro-choice values. Our staff, our board, our clients are made up of the women who we serve, African, Caribbean, Latin American, and South Asian populations. We have 15 languages on staff. The staff represents this population at about 98%, the board at 100%. We promote women's leadership as opposed to women's empowerment. I don't feel I have any more power than the client sitting across from me, so I have no power to give her. But I do encourage her leadership and growth to become a leader. We've spent an enormous amount of work building trust with the communities that we wanted to serve. So just because I come from a particular community doesn't mean that I'm someone to trust. It's a good start, but I need to prove myself. We also looked at something called a cultural insider model in terms of FGM. Women who had experienced FGM would be the experts as opposed to the providers of the service. And that was who was going to move us forward in the eradication of FGM in Canada. And we also felt we were a feminist bridge. And when I say that, I talked earlier about the tension between Western feminists wanting to save women who are experiencing FGM and the African feminist or Africana feminist, or all the other terms we might use in Africa instead of the traditional feminist label, who are already doing this work. And for many of us, like myself, immigrated as children, and so we've lived in both cultures, and we understand both cultures in a particular way. So it was a nice way to not just cut off Western feminism and the work that they were doing, but to bridge the two groups, because we all needed to work together if we were going to eradicate FGM. The need for allies is very significant in this fight. It can't only be the people who are impacted by FGM who always have to stand up and put their personal lives on the table and tell you about their experience. It also needs allies who can support and use their power and leverage in their own communities to work together. So for success to occur, we believe that you needed to understand FGM as both a health and a human rights issue. It was going to require both human and financial resources. We heard Kauser talk about oftentimes as activists, you're paraded around and expected to do all these events and go to all these places without any remuneration, without any support for the rest of your life, the other parts of your life, and keep fighting without any financial support. So we didn't want to put the women from impacted communities in that situation. We also knew that we needed to change policy and legislation, not just within Toronto or the Ontario community that we were working with, but nationally, and we had never done that before. And we also understood that it was going to require linkages and partnerships between the impacted communities, service providers, and government bodies. So we had to bring all three of those sectors together to address the situation. So in terms of leadership development, we didn't set out to be leaders in this area. But we were being approached by the communities to do this work for us. You say you serve us. We're one of the largest populations in Toronto in terms of the African population, and you don't have any leadership ability in this area. So it was a very strong challenge from the community that pushed the organization forward in terms of saying, okay, we need to do something about this. So before you start throwing stones at other people, you have to clean your side of the fence, I think is the term. So we went about strengthening our internal capacity. So in terms of our training, so bringing in people from the UK, from the US who were doing this work, making sure all of our healthcare providers were adequately trained so that they could provide services, so that we all understood the issue from a social perspective, from a political perspective, as well as a medical perspective, as well as from a spiritual perspective. So not just focusing on me, the healthcare provider, but what are all of the aspects of a woman's life that I need to consider if she's experiencing or having undergone FGM. We needed to establish an internal unified FGM position. So for many of us, we're coming from countries where FGM is practiced, or we ourselves have experienced FGM. So we had very differing views, because some of them are personal. In my community, who am I going to go and talk to about FGM? We're really talking about circumcision. And when I tell them I use FGM because mutilation is a more accurate account of what happens to women, you know, that takes a lot of courage to actually challenge your community in that kind of way. So some of us were going through our own personal struggles, as well as our professional requirements to work at Women's Health and Women's Hands. So we had to work through that issue with our staff. The staff training, as I said, on social and cultural issues, you don't want the first time that you meet someone who's experienced FGM to be on your examination table as a physician. So you don't want to wait until the person is in your exam room before you've had any experience with the culture, the community, the person, all of those things. So how do we get our providers out into the community to meet with community leaders, to go to cultural events, to have a solid understanding of the community before you are going to start treating them? And I talked about specializing in primary healthcare training. So this took quite a bit of time for us to get settled as an organization to effectively provide services. And then we decided we needed support. So if things are working well in our organization, how are we going to convince the rest of the world around us that we need to address this issue on a very systemic and political level? So in 1999, Women's Health and Women's Hands, along with another organization which was also seeing a large number of women from communities that practiced FGM, the Center for Victims of Torture, along with Toronto Public Health and the Somali Women's Advocacy Group for Community Development, we formed a working group so that we could collectively work together to start lobbying at a political level. At that time, the focus of the group was to provide recommendations to Toronto Public Health and to share our collective expertise in advocacy, political lobbying, and healthcare provision. So we formed a coalition of organizations that had different types of expertise that we thought we could move an issue forward. And we definitely took our lead from the Somali Women's Advocacy Group. And I want to emphasize that because sometimes as organizations, you have a particular level of power, but you don't really. I think the power in this situation, that's why we're called Women's Health in Women's Hands. We believe that women are experts in their own lives and women are experts in their health care. So we needed to really take direction from the women who were experiencing the issue. That group met for a year, and in 1991, we felt strong enough and capable enough to start lobbying larger bodies. And the first group that we lobbied as an organization was the College of Physicians and Surgeons of Ontario. If we could provide services at Women's Health in Women's Hands, we needed to be able to refer women to other services. We needed them to be able to go and have positive experiences in the healthcare system, and we needed to ensure that all of the physicians in the province were on board with that agenda. So we made a submission to the college task force on sexual abuse of patients, and that submission was supported with a submission from the medical officer of health in Toronto. The following year, the CPSO, based on that lobby, announced that female circumcision, excision, and infibulation were banned, and that the performance of any of these procedures by a physician licensed in Ontario would be considered professional misconduct. This was a big win for us. And they went on to further say that it was illegal to re-infibulate women after delivery. You're going to hear more about clinical care. So for those of you who may not know about infibulation or re-infibulation, I'm not going to get into the details, but women who've undergone FGM, once they deliver, would be re-infibulated. This would not allow a physician to re-infibulate women. What that does to the woman, however, is now leave her in a situation where her body has been changed in a way that she hadn't planned it to be. So there's a whole other issue that we had to deal with there. We moved them from the College of Physicians and Surgeons to looking at the protection of young girls. And in 1992, Women's Health in Women's Hands, along with 3 leaders from the Somali community, conducted training and facilitated child protection strategy discussions with our children's aid societies in Toronto. And subsequently, after that training and work that we did with Children's Aid, CAS issued a statement asserting that FGM constituted a form of child abuse under the Child and Family Services Act of 1984. So we've moved now. We've got the physicians on side, we've got child welfare on side. So you can imagine it's an enormous amount of work that we're doing that we're not funded for. We're funded to be healthcare providers, to not be doing all of this political advocacy, but we understood the importance of supporting a community to eradicate FGM. So in 1992, we applied for funding, and we received the first funding for an FGM program in Canada, and it was from the Women's Health Bureau at that time, which no longer exists, of the Ontario Ministry of Health. And the goal was to develop workshops, education training materials, for providers as well as women from the communities. So when I talked about changing legislation, it doesn't work if you don't inform the community that the legislation has changed. So when you do go to deliver your child, this is what's going to happen by law, right? If your child is taken back home and FGM is performed, this is what's going to happen. So you have to not only provide education for the service providers, but also the communities who are going to be impacted by those legislative changes. That first program and project was instrumental at Women's Health in Women's Hands, and I think it really changed everything that we did, not just around FGM, but how we worked as an organization. The project developed an extensive lit review, and we collected every piece of information available on FGM, and it resulted in one of the only collections of FGM material in the world. So people were coming to Women's Health in Women's Hands for information. We had a library set up, so it was very well organized. But as Kaiser mentioned, the internet has taken over, and we have put most of that material away because it's online. You can watch just about anything online now. But at that time, it was very important. The creation of self-help groups for leadership development with women from impacted communities. We developed a Somali women's facilitator group. It consisted of 12 women who were doctors, nurses, lawyers, educators, and community leaders, and they had all undergone FGM. And that reference group is what guided our organization and then provided training for women throughout the various communities so that they would develop leadership to do advocacy and have support. So that it's not just me saying to my father, I need to do this. I knew I had this reference group who also were women who could support me in doing that type of work. We held the first FGM community forum for women from impacted communities at that time. 60 women participated. And we also conducted workshops throughout the city and throughout the country, actually, for healthcare providers and medical professionals on FGM. And we still do that today, primarily with medical schools, nursing schools, midwifery schools. So that model still exists today. The number one recommendation that came out of that project, and unfortunately it was project funding, so it was time limited. And for many of you who work in social services, we know the difference between core funding and project funding. But the key recommendations that came up at that time were the formation of an interministerial task force on FGM. The only way that we were going to change legislation in Canada is if all the ministries that were involved, child welfare, the Attorney General to deal with violence, health, all of those ministries had to sit down and have a conversation. We needed to increase access to primary health care for women who were experiencing FGM or had undergone FGM. We know that because of gender, because of race, and because of all kinds of things that we don't need to rehash here, that accessing health care is already a challenge, let alone I have this other thing that you can't deal with when I get there. So we needed to address that issue. We needed more research. We needed core funding. We needed provincial, national, and international collaborations. You're all sitting in this room, primarily from this province. We need to collaborate with Ontario that has already done an enormous amount of work. And we also need to connect with the international organizations that are doing this work. And I don't mean Western countries. I'm talking about local FGM eradication programs on the continent that are doing enormous amount of work with limited resources and very successful. So while I'm here in Canada struggling to address this issue, there are many programs in Africa that are working extremely well. So those are the ones I need to be working with and looking at, as opposed to thinking I need to raise money to save them. Usually the calls I get at Women's Health and Women's Hands are about, we want to donate money to those women in Africa doing this work. And I'm like, they're doing it. You know, why don't you put some effort into addressing some of the barriers that we're experiencing here in Canada? But please send the money anyway. We'll take the money. That's okay. And then we also needed to have meaningful engagement with impacted communities. So in terms of success, Women's Health and Women's Hands at the end of this program did receive core funding for an FGM-focused health promoter, and we still have that position today. We were able to lobby provincial and national organizations to adopt anti-FGM resolutions, and we began lobbying the provincial government, and that led to the development of that provincial interministerial task force on FGM in 1994. So we were able to get all of the ministries concerned to sit down and have the conversation that needed to happen. And finally, in 1994, the Canadian Advisory Council on the Status of Women, through our work and efforts, called the federal government to eradicate FGM. So finally, the proposal was put on the table at the federal level in 1994. So that, in 30 minutes, is the organizing history, anyway, of FGM. Obviously, enormous amounts of work have happened since 1994. And we know that FGM is illegal in Canada, so we know that there is success after this slide. But we keep having these conversations. I keep having to have these conversations, and I think there needs to be some way for us to hold on to this memory and move forward. We've gotten stuck in Canada. We're stuck at a particular point, and we're not really sure how to move forward. And I think as we move provincially, we see as new immigrants and as new communities start emerging in other provinces, we start the conversation at the beginning again. So we have to figure out some way that we can work collectively to become versed in the issue, to move away from some of the racist ideologies from the past, and to ensure that all women who are coming to Canada, regardless of where they're coming from, regardless of their cultural practices, religious practices, even just local family practices that people tie up into culture and religion, that they're able to be accepted. And that comes with the change of the Canadian culture. So it's about how do we become a truly receiving country, as opposed to the one that is on TV at the UN and promoting itself as the most receiving country, the most cosmopolitan cities, the most diverse country in the world. All of those things are true, but we need to back it up with real action and real support for people who are coming into Canada. So I'm going to stop now. I know there's a Q&A period. And I hope you have a fabulous, fabulous next 2 days. And I want to thank the organizers and for all of you for coming this morning. Thank you.